guys. Today we'll be discussing abnormal head posture, its various reasons, and how to remember the position that the head assumes in palsies of the various extraocular muscles. Okay, so I hope everyone is doing well, and let's get started. Okay, so one thing that I do want to discuss before I move on to the main part of this video is the reason why the head might assume an abnormal posture. Okay, so the reasons might be ocular or non-ocular, and by this I mean not just squint, okay, even in case of nystagmus, even refractive errors, ptosis, visual field effect. So essentially any case where the images on the two retinas are not corresponding and the patient might develop diplopia. Okay, that is when the head assumes a posture so as to compensate for this and avoid diplopia. Okay, so in an ocular cause, the only reason why the head posture is abnormal is so that the patient can avoid diplopia. Whereas in case of non-ocular causes, any orthopedic cause or neurogenic cause, like maybe an abnormality of the sternocleidomastoid muscle or even just habitual, the patient's head posture is not because of diplopia but mechanical or neurogenic. Okay, so in these cases, how can you differentiate? Is the cause ocular? Is the cause non-ocular? One way to differentiate is to observe the patient when the patient is asleep. So when the patient is asleep, his eyes are closed. The patient does not have to make any effort in order to avoid diplopia. So had it been an ocular cause, then the patient's head will be absolutely normal. Okay, the head posture will be absolutely normal. Whereas if it's a non-ocular cause, then the patient's head posture will remain just the same as it is when the patient is awake. So that's how you can differentiate between ocular and non-ocular causes of abnormal head posture. Okay, so moving on to the next part. Now, before we actually get started on how to remember the position of the head in the various kinds of squints, something that you should know is which muscle acts in which gaze. Okay, if you do not know this, you won't be able to remember the position of the. You won't be able to understand what we're going to see after this. Okay, and a lot of people do find it difficult to remember this. One way you can remember it is just from the name of the muscle. Okay, we have a rectus muscle and we have an oblique muscle, right? So rectus translates into straight, and oblique in very simple words translates into not straight. Okay, so how to remember? Whichever side the patient is looking, he's looking straight to that side, so the ipsilateral rectus is going to act. Okay, what do I mean by this? Here the patient is looking to his right and he's looking up, so he's looking right and he's looking up, so it's going to be the right superior because he's looking up, and rectus. Okay, so whichever side is going to be the rectus of that side, because rectus means straight, and whichever side he's looking, whichever direction he's looking, is going to be the corresponding rectus. Up here the superior, down here the inferior, and for the opposite eye it's going to be all opposite. So corresponding to the right superior rectus, you're going to have the left inferior oblique. Okay, let's try this with another case. Let's try it with this case. Okay, let's try it with this case. So here the patient is looking left and he's looking down, right? He's looking left and down. So it's going to be the left inferior rectus. As I said, whichever side he's looking, it's going to be the rectus of that side because he's looking straight to that side, and whichever direction he's looking is going to be the corresponding rectus. So inferior in this case, and for the opposite eye, it's going to be all opposites going to be to the right superior oblique. Okay, so if you have difficulty remembering which muscle acts in which gaze, you might want to remember it this way, and if you're familiar with it, then that's absolutely great. Okay, fine, go on to the actual part. So here we're going to discuss how to remember the position of the head in the various palsies. So which muscle is acting for this eye in this gaze? He's looking to the left and he's looking up, right? Left and up. So if he's looking left and if he's looking up, it's going to be the left superior rectus. I'm going to draw an arrow in this direction. Okay, so I'm going to draw an arrow like this. And all of us have studied vectors. So I'm going to break this up as you break up a vector into a horizontal component and a vertical component. This horizontal component is what will tell you about the face turn. This vertical component is what will tell you about the chin lift. And when I draw the original arrow towards the vertical arrow, mind you, I'm drawing it towards the vertical arrow, okay, not the horizontal one, I'm drawing it towards the vertical arrow. That will tell you the direction of the head tilt. Okay? तो कैसे करेंगे ये? So in case of a left superior rectus palsy, the face turn is to the left, because this is your left side, this is your right side. The chin is up. You can see that the arrow is up, so the chin is up. The face is turned to the left, and the head is tilted towards this side. Okay, the head is tilted towards this side. This is your right side, right? So the head tilt is to the right. Okay, so I made an arrow in the direction of the gaze, in the direction of the muscle acting in that case. I broke it up into a horizontal and a vertical component. Horizontal tells me about my face turn, vertical tells me about the position of the chin. And when I draw the original arrow towards the vertical component, I get the position of the head. Okay, let's try it with the other muscles. Okay, for this eye, which muscle is acting, he is looking for this eye is going to be the right superior rectus. So for this is going to be the left inferior oblique. So what about this muscle? I'm drawing an arrow again in this case, breaking it up into a vertical component and a horizontal component. So my face is turned towards the right, my chin is up, okay, my chin is up, and when I draw it towards this side, when I draw my original arrow towards the vertical, I can see that the head is tilted towards the left, okay. So face turn in case of a left inferior oblique is to the right, the chin is up, and the head tilt is towards the left. Okay, fine. The next few muscles, this is the right inferior rectus. I hope nobody has a problem understanding that. So I'm going to break this up again into the two components, right? And this tells me that my chin is down, okay, and my face is turned towards the right. This I'm going to draw it towards the vertical arrow, right? So when I draw it towards the vertical arrow, this is how my chin is turning, mind you. ये नीचे की तरफ है, okay? So your head will automatically turn in this direction. What do I mean? Chin अगर ऐसे turn करता है, तो head तो ऐसे ही जाएगा. This is this, for example, this is somebody, okay? If the chin turns towards this direction, the head will automatically turn in this direction, so that he becomes like this, right? So if your chin is turning towards this direction, your head tilt is going to be towards the right. Okay, so in case of a right inferior rectus, I'll see the chin is down, the face turn is to the right, and the head tilt is towards the right as well. Okay, last muscle. This is your right superior oblique, right? I'm going to break it up again into a vertical and a horizontal component. So chin, as you can see, is down. The face turn is towards the left, because this is your left side, and the head tilt, again taking cue from the previous one, I'm going to draw this towards the vertical. So the chin is going like this, which means that automatically the head is going to go like this. So the head tilt is again towards the left. Okay. Now, two things that I also want to discuss right now, since we are discussing squint, is an exception to the two laws that we read about in squint. One is Sherrington's law and the other is Hering's law. So Hering's law is a law of equal innovation. Sherrington's law is reciprocal innovation. Dewey's retraction syndrome, we study about this sometimes. We don't really know what's going on in DRS. So what is DRS and why does it happen? And why am I saying that DRS is an exception to Sherrington's law? So this is an eye, okay, and here I have, this is a nose, okay, so here I have the medial rectus and here you have the lateral rectus. So normally we know that the lateral rectus is innervated by the sixth nerve and the medial rectus by the third nerve. So when the medial rectus is supplied by the third nerve and the third nerve fires, the lateral rectus automatically gets a command not to contract, so that's why the eye can adduct smoothly. That is Sherrington's law of reciprocal innervation, which means that the two muscles are not contracting to the same degree. Okay, lateral rectus, medial rectus, not receiving the same amount of nerve supply, so that the eyeball does not receive the command to go medially and laterally at the same time. Okay, that's understandable. Now, what happens in DRS? In DRS, the sixth nerve that normally supplies the lateral rectus is hypoplastic. Okay, so if it's hypoplastic, in order to compensate for that, the third nerve now comes to supply the lateral rectus. So what happens? The medial rectus and the lateral rectus are now being supplied by the same nerve. So these two muscles are receiving the command to contract at the same time. Because the lateral rectus and the medial rectus are now receiving equal nerve supply, this is why it is an exception to Sherrington's law. What happens when it receives the same nerve supply? The eyeball retracts, okay, which means it goes inside. So I want you to compare the width of the interpalpebral fissure here with the width of the interpalpebral fissure here. So here the eye is abducted, look at the width here, and here the eye is adducted. You can see that the width has reduced, okay. So when the eye is adducting, the MR and the LR are contracting together, which is why it is retracting. And when the eye is retracting or going inside, you can see that the width of the interpalpebral fissure is decreasing. Okay, there are three types of DRS according to Huber. Type 1 is when the defect is seen in abduction, type 2 is in adduction, type 3 is in both. So what do I mean by this? Here you can see that the defect is seen in adduction. Okay, in abduction, it's the same in both eyes. In adduction, you can see there's a difference in the width of the interpalpebral fissure between the two eyes. So this tells you that the defect is in adduction. So it's a type 2. Type 1 is a defect in abduction, type 2 in adduction, type 3 in both. You can just remember this alphabetically. B पहले आता है, फिर D, and then both. Okay. These are just types of DRS. But the main thing that you have to remember is that DRS is an exception to Sherrington's law. Why does it happen? The sixth nerve is hypoplastic. So now the MR and the LR are being innervated by the same nerve. So they contract together. When they contract together, the eyeball goes inside. It retracts. So the interpalpebral fissure, it reduces. Okay, it reduces in width. Fine. The last topic for today is an exception to the other law, that is Harrington's law. Harrington's law, we know, is the law of equal innervation, right? So why am I saying that this entity called dissociated vertical deviation is an exception to Hering's law? See, normally, suppose I have these two eyes, okay? Suppose I have a right hypertropia, okay? A right hypertropia. This is essentially the same as a left hypotropia, okay? Because both the eyeballs move together. What do I mean by this? Suppose I'm doing a cover uncover test for this patient, okay, and I cover the patient's eye, I cover this eye, okay, so automatically this eye is going to move to this position, okay. What am I going to get? I'm going to get this eye in this position. Now behind the cover, in case of the left eye, this eye will have moved here, okay. This is because both eyes are associated, okay. Since both eyes are associated, whenever one eye moves by some degree, the other eye moves by the same degree, so that there is no vertical deviation between the two. By dissociated vertical deviation, I mean that when I cover this eye, in case of a patient who has DVD, okay, what is going to happen? This eye is going to remain as it is, and this eye is going to remain here. So no movement is going to occur. So both the eyes are dissociated. Why am I saying it's an exception to Hering's law? Because Hering's law means equal innervation, which means when this eye was moving by a certain degree, the other eye was moving by the same degree. But in this case, both the eyes are dissociated because they are not moving by the same degree, and the dissociation is vertical. Okay, it's a hyper-hypo relation, which is why dissociated vertical deviation is an exception to Hering's law. Well, that's all I wanted to discuss in this video. I hope you've understood how to remember the position of the head in the palsies of the various extraocular muscles. What you can do is just try it out for yourself, okay? Just choose any muscle, choose any gaze, choose a muscle, and draw the line, draw the vectors, check for yourself, match it with your notes. You do it once or twice, you will definitely remember. Okay, so just try it for yourself, and I hope the exam goes really, really well for you. All the best, and see you next time.